Good afternoon. Thanks for inviting me for MyoIn conference. I'm going to present on treatment of myositis. Give you an overview. My name is Rohit Agarwal. I'm an associate professor of medicine in Division of Rheumatology at University of Pittsburgh. So first, I would like to just give you a little bit of introduction slides on myositis. And I know you all know myositis very well. To understand the treatment of myositis, we need to obviously first understand what classification criteria we're talking about and what clinical subsets we're talking about. So myositis is typically divided into these clinical subsets of adult polymyositis, necrotizing myopathy, adult dermatomyositis, and another unique subset of adult amyopathic dermatomyositis, juvenile dermatomyositis, cancer-associated myositis, and connective tissue disease-related myositis. And another one would be inclusion body myositis. So when we're treating our patient, we need to understand what clinical subset we are treating. And oftentimes, when I see patients in my clinic, especially with refractory disease, especially when patient comes and says nothing is working, my first question is the diagnosis correct? And oftentimes, I find that may not be the case. And the reason for that is Bowen and Peter classification criteria for PM and DM. It works really well for dermatomyositis mainly because of the skin rash, a specific skin rash of cotton papules and heliotrope rash that can be recognized by any trained rheumatologist, dermatologist, and neurologist taking care of these patients very well. So we have a high specificity because of the rash for dermatomyositis through Bowen and Peter classification criteria. However, Bowen-Peter classification criteria does not work for polymyositis. It's a very poor specificity and is highly sensitive for polymyositis diagnosis. And that's because the top four features of symmetric proximal muscle weakness, muscle enzyme elevation, myopathic EMG, and characteristic muscle pathology of muscle inflammation can be seen in various different mimickers of polymyositis, which includes inclusion body myositis, muscle dystrophies, metabolic myopathies, drugs, steroids, thyroid disease, neuromuscular disease, and malignancy. So whenever you have a patient with polymyositis or necrotizing myopathy and meeting Bohan and Peter classification criteria who's not responding to your treatment, often think about these alternative diagnoses first and reconsider the diagnosis before you start giving them more immune suppressive drugs. Another point I like to often emphasize that generally tissue is the issue, so getting a muscle biopsy and understanding what pathology you're dealing with could give you a lot of insight in how to treat this patient, how severe is the pathology, what drugs should I use, what clinical subset do they belong to, and so on. So my bias is always to get a muscle biopsy, even if you have a clear-cut diagnosis. In most cases, it will be very helpful. Other point that I like to make is myositis is not a single disease, not a disease of muscle and skin. It involves various other organs, including interstitial lung disease, calcinosis, dysphagia, polyarthritis, Raynaud's, and etc. Whenever we're treating myositis patients, we often want to see what organ manifestations we are talking about. Is it only a muscle problem? Is it muscle and skin problem? Is it an interstitial lung disease, which is a bigger problem for us than muscle and skin in some cases? Or is it the calcinosis that is progressive and bothering the patient more? So what are we dealing with? And that can really help you to shape your treatment paradigm for any particular patient. I'm pretty big on myositis autoantibodies. As you know, myositis antibodies are highly specific for myositis, recognize a unique clinical phenotype, and I use them obviously for diagnosis and prognostic reasons because they help me to understand what clinical phenotype this patient might have. But more and more, we have started to use these antibodies for treatment purposes as well. And I will try to explain it in subsequent slides how we can use antibodies for treatment purposes. With that introduction, let's start with a case to go into actual drugs that we use to treat myositis. Case 1 would be a typical case. This is your 47-year-old female who presents with a cotton papules and mild muscle weakness. Patient CK level is 4,500. Patient has a myopathic EMG. Muscle biopsy shows perivascular inflammation, atrophy, as well as perivascular inflammation, which is typical for a patient with dermatomyositis. Autoantibody testing reveals patients with NXP2 antibody. So one of the first questions that I get asked is, how should we treat this patient? This is a new diagnosis, mild disease. Should I use prednisone alone or should I use prednisone with methotrexate? To answer this question, we will take help from a randomized controlled trial done recently in juvenile dermatomyositis patients. The only caveat of this trial was this was an open label trial. Anyway, these patients are treatment naive juvenile dermatomyositis patients. So it's a new patient, new diagnosis. These were all given pulse steroid for 3 days and then randomized to one of the three groups, prednisone, prednisone with methotrexate, or prednisone with cyclosporin. And then they were followed for several months. What clearly showed is there was the outcome was print to 20% improvement, which is similar to what we see, what you know about ACR 20% improvement. So it at least showed that if you give combination therapy, either with prednisone with cyclosporin or prednisone with methotrexate, you're going to have a lot better improvement rates as compared to prednisone alone. Now, prednisone alone does work in 50% of patients, but you're going to get a lot more for by using upfront combination therapy. And it goes all the way up to 24 months, so the effect is sustained. Also, the time to clinical remission was far better with methotrexate and prednisone as compared to prednisone alone, and was even better than prednisone with cyclosporin. So my favorite is prednisone with methotrexate, at least from this trial. That's my takeaway. Treatment to failure was much earlier in prednisone. We know that very well. Patients don't tolerate prednisone. Oftentimes, we have to taper it fast and they flare up. However, methotrexate or cyclosporin combination patients did much better. Another problem we face in when we use combination therapy is it more side effects, and that is the case. I mean, if you give two drugs as compared to one drug, you're gonna see more side effect profile, especially with infections. But all of you are trained how to deal with these infections effectively. I would like to point out most of the non infection side effects, like GI side effects or skin side effects, were much more prevalent in cyclosporin group as compared to methotrexate group. Again, another reason that I like to use methotrexate over cyclosporin, um, because of the side effect profile is far better for methotrexate and we are more comfortable using methotrexate. And we also know that steroid alone is bad in myositis. There's a whole laundry list of steroid side effects that we see on a daily basis. But more importantly, if you talk about efficacy from steroid alone, we know the complete remission is achieved in less than 30% of cases. It is associated with flare in up to 50% of cases, and there's a significant lack of full muscle function recovery even for the patients who improve. So, for various reasons, like to use combination therapy. Now, this question of should we use azathioprine or methotrexate as the first line combination therapy agent, I would say most studies have shown very similar efficacies. We don't have a prospective study. We're talking about really retrospective case series and retrospective control studies. My take on it is I use methotrexate whenever I can, unless I'm forced to use azathioprine, which would be in a patient with liver disease, patient with alcohol issues, or patient with interstitial lung disease where I'm worried about using methotrexate. So, but both are fairly good agent, I would say, and I've used both of them with fair amount of success, at least as first line. Next question comes is rheumatologists are very comfortable using combination therapy. So if it works for rheumatoid arthritis, why won't a combination therapy work for myositis or other chronic inflammatory diseases? And that's the to answer that question. This was a study done years ago where they randomized patient. These were 30 patients with resistant myositis who had either failed methotrexate alone or azathioprine alone previously. And these resistant refractory patients were then randomized to getting either oral methotrexate and azathioprine combination, and other 15 patients got IV high dose IV every 2 week methotrexate. And what happened clearly was whenever you were given combination therapy, you were far better than a single agent, even in a higher dose. So at least from this study, the take home message is if you need to use combination therapy, you should not be shy away from using combination therapy. At least methotrexate with azathioprine, but I also use other combination therapy which include mycophenolate and tacrolimus. So if we put together a flow chart of pharmacological therapies of IAM, you will say steroid would be number one. Obviously, we have to use steroid. We haven't gone away from using steroid completely yet, but I would like to add methotrexate as a therapy right away, so that I can also taper the steroid faster and get to a lower dose faster. Now, moving on, I would say case one continued. This becomes a refractory case later on. So this patient was treated with methotrexate and prednisone over 12 months. Subsequently, initially the patient really responded well. However, on tapering of prednisone, which is often the case, the patient flared up. Patient had worsening of the rash and weakness, and the CK again went up above 1000 after getting normalized. So in this case, I would like to think about more treatment options which I would use for refractory cases. And a refractory patient would be a patient who has failed a steroid and additional methotrexate or azathioprine or combination. And my usual suspect for treatment of refractory myositis are following. Could I use IVIG? Could I use mycophenolate, rituximab, tacrolimus, cytoxin? Pick your poison. And I like to go with mycophenolate first, and I'll try to show you some data on mycophenolate. So in subsequent slides, you will see this is a graph that I use to explain the strength of the literature or the data for any particular drug or studies. So in this, you will see that it's represented case reports, case series, retrospective studies, retrospective control studies, prospective open label studies, followed by randomized controlled trial. And as you move more towards the right of the screen towards randomized controlled trial, higher the strength of the study. And then I represent each study by a bubble or a ball, and bigger the bubble or the ball, higher the N for the study, better the study is. And then we represent the indication of the study by different colors. For red would be muscle in PM and DM, skin only would be yellow, ILD would be orange, and green would be JDM patients. If you look at the data in mycophenolate, it will be very clear to you that we really don't have good prospective or control studies. We have a retrospective study. However, we have a large number of retrospective study which gives us some confidence in the data, and also we see that in our clinical practice as well. One of the best studies done on ILD patients with mycophenolate associated in patients with ILD associated with myositis was this 32 patient study, in which what they showed is when the MMF was given, patient had some significant improvement and without any decline in their forced vital capacity. And this improvement was even better than what they have seen in other diseases that they treat with mycophenolate, like rheumatoid arthritis or systemic sclerosis. Not only that, after giving mycophenolate, they were able to taper down steroids significantly, and that's usually one of our goals in our patient. In terms of skin, you will see there's few studies done where there's significant improvement in skin, and in general, mycophenolate is a very good drug for inflammatory skin diseases. 50 patient study on juvenile dermatomyositis showed significant reduction in skin and muscle parameters. And also, there are multiple retrospective studies done on muscle disease in PM and DM where they have shown significant efficacy. However, most of these studies are retrospective studies. Then, going on to my other drug, tacrolimus. How about tacrolimus? How does tacrolimus data look like in myositis? I would say it's better than mycophenolate because not only we have retrospective control study, we actually have a prospective study on tacrolimus in myositis. This was a very good study in which they showed they were only 9 patient study, but they were able to show significant improvement in muscle grades, CK level, and dose of prednisone after giving tacrolimus, and this was prospective open label study. Another reason I like tacrolimus is ILD patients. And at least Japanese folks have shown that there is significant survival benefit if you give tacrolimus with steroid upfront as compared to steroid alone. So about 25 patients were given tacrolimus and steroid in combination. Now many of those patients were also on cytoxin, but at least they were able to show in a controlled manner uh, um, a significant survival benefit, and just generally no better outcome measure than survival. There's no discrepancy in the decision making here. Are you dead or not? So if you are able to save life, that's generally a good thing. And tacrolimus was also studied in our center, where we actually studied refractory patients with ILD associated with myositis, and showed that after adding tacrolimus, we were able to actually improve forced vital capacity. And these patients have, on an average, previously failed two agents. Why we don't like tacrolimus sometimes is due to its significant adverse event and profile, and these adverse events are very different than a common rheumatologist, neurologist, or dermatologist is used to deal with. However, I would like to reassure you most of these severe side effects and the frequency and severity is more dose dependent of tacrolimus. And we see more this in transplant literature where they uses doses of trough of 14, 15, 16, and even higher. When we treat myositis patient, we don't use the dose that is used in transplant literature. We use lower doses, and our goal is generally a trough of 8 to 10, and even lower for maintenance treatment. And 8 to 10 trough level is more for induction treatment. And when we do use the drug tacrolimus in those doses, we don't see that kind of severity or frequency of side effect. Obviously, we still have to monitor them for all of these side effects because they can happen for sure and does happen. So adding the second line agent would be my combination therapy, mycophenolate, tacrolimus, and if tacrolimus is too expensive, you could use cyclosporin. I personally don't like cyclosporin because I think the side effect profile is worse than tacrolimus, but the cost is much cheaper. But if you know how to monitor these patients, then you might be okay. So going to the case 2, this is a 56-year-old female who presents with mechanics, hand, polyarthritis, Raynaud's, and ILD. This is your classic antisynthetase syndrome patient with normal CK level, no muscle weakness, no other rashes, but has positive PL7 antibody. This patient was initially treated with prednisone and azathioprine with significant improvement. However, 1 year later, she flares up with dyspnea and forced vital capacity is 67%. At that point, she was treated with prednisone with mycophenolate and tacrolimus combination, again improved, and she did well for 2 years. But now she's again having one more severe flare up, now leading to respiratory failure and new oxygen requirement with a forced vital capacity of 54%. So, what should we do now? And this is a kind of a case where I would like to use rituximab. And this is the data shown on your screen for rituximab, mostly retrospective studies, but on ILD, on skin, on muscle, all of them. And also, if you look at this largest study done on ILD, 24 patient study, they were able to show that patients after getting rituximab, they were able to improve their forced vital capacity, FEV1, DLCO, and subsequent to that, we have also done another retrospective study in which we were able to replicate these results. Going from ILD, ILD, I would say rituximab would be really drug of choice in this kind of severe ILD, especially if it's antisynthetase syndrome. Going from ILD, what about muscle? And we did this large myositis clinical trial, rituximab in myositis clinical trial called RIM trial, in which we treated about 150 patients with DM and PM and 50 patients with JDM. And this was a randomized placebo phase design in which patients got drug early, which means rituximab at week 0 and 1, or the drug late, which would mean rituximab at week 8 and 9. And unfortunately, the trial primary results were negative. And if you look at the cohort results, entire cohort, the graphs were overlapping, which basically means the trial kind of failed. However, if you look at the patients, how many patients got better in the trial, about 80 to 85% patients got met the definition of improvement in the trial. That means this drug might work, but the trial might have failed. And the trial design, one of the caveat was there was only 8 weeks difference between the two treatment arms. Both got the treatment, but only 8 week difference was not enough to show the difference, perhaps. But also, I wanted to explain that why I think the drug really works is that these patients, when I looked at the data, these patients on an average has failed 2 to 3 other non-steroid agents before they got into trial. So these were really refractory patients, and to see about 80 to 85% improvement in really refractory patient is remarkable. Then we asked a question that which are the patients who are getting really better as compared to who are not getting somewhat better. And it was very clear to us that patient, if they don't have an autoantibody, the single most predictor of patient's response to rituximab was autoantibody profile. If you don't have an autoantibody, you're not going to respond well to rituximab. Whereas if you have myositis antibody, you're going to respond better. And amongst those antibodies, if you have Jo1 or MI2 antibody, your success would be far better. So anti-synthetase syndrome, this is my drug of choice in many cases for that reason. Other two reasons where rituximab helped in myositis patient was juvenile dermatomyositis, and the third predictor was less damage, like early on. So, for as a third line treatment, I would like to add rituximab. I would like to add cyclophosphamide, and combination therapy of rituximab and cyclophosphamide is often used in more severe ILD patients where we really need to save somebody's life and we don't have much time. So, going from there to case 3, so we have a 52-year-old white male here presented with severe rash and muscle weakness, has been refractory to various treatments for last 2 years. The rashes include Gottron, heliotrope, VNAC, and Scholl sign. The patient has severe muscle weakness, a CK of more than 5,000. The autoantibody profile is negative. However, EMG and muscle biopsy is fairly classical, and there's really no doubt in the diagnosis here. Patient has previously failed prednisone, methotrexate, tacrolimus, and mycophenolate. And the doctors are not able to taper the steroid below 20 milligrams of prednisone despite being on mycophenolate and tacrolimus. So, in this is a case where I would like to use IVIG. And if you look at the data on IVIG, you will be impressed. We have the most data we have of any drug in myositis is IVIG, including prospective randomized trial. Now, there's various reasons we don't use IVIG in all cases, and there are various reasons it's not the first line drug, cost being one of the main reason, I would say, but logistics is another reason. If you give this drug, let me point out to the one of the best study done by. So it was clear to me, at least in this randomized controlled trial, that the drug really works. However, we don't have an FDA approval for it because we haven't really proven beyond doubt that this drug really works in this disease category. Now, there are several pros and cons of IVIG, and I will not go in detail about the pros and cons of IVIG here, but I would like to emphasize that this is a first line treatment for me in pregnancy, in cancer, in dysphagia, in patients with infection, in patients with severe refractory rashes, and calcinosis. For all of these things that I've told you, it's the first line treatment for me. There are significant side effect profile that you need to know, and if you give it carefully, you won't have any trouble. But most of the side effects are rate and dose dependent. So if you give the drug higher dose and faster rate of infusion will lead to more trouble. So a slower rate of infusion and a lower dose would be much easier. So adding IVIG to parallel to first, second, and third line because we could use it and whenever we need to use IVIG, and it could be used in combination with other treatment options that we have first, second, and third line. Last few slides as a summary. I'd like to have you pay attention to this. This is a refractory myositis patient. Depends on what disease you're treating. If you're treating with ILD, if you're treating anti-synthetase syndrome or other antibodies like MDA5 antibody, I would like to go to mycophenolate or tacrolimus. Followed by rituximab, and perhaps maybe adding cyclophosphamide if it's ILD and not getting better just on rituximab, followed by clinical trials. If you have a patient with SRP, again, I would quickly go to mycophenolate or tacrolimus. But at that point, if patient is refractory, I would quickly move to rituximab on IVI or IVIG. If you have a patient with HMG-CR antibody or statin-induced immune-mediated necrotizing myopathy, those tend to be more elderly patients. I would go directly to IVIG. Many case series have now shown that how IVIG could be very effective as a single agent, a non-steroid single agent without any use of steroid. They can improve these patients, and that makes sense because patient with SRP and HMG-CR antibody does not have much inflammation on the muscle, so the inflammatory cells are not killing the muscle fibers. So it must be another mechanism, and we suspect that the mechanism is complement-mediated mechanism. And if you know how IVIG works, it really works through complement inhibition. So we think this is a good drug for SRP and HMG-CR. If you're dealing with a skin disease, a bad skin disease, or juvenile dermatomyositis, mycophenolate would be a good drug of choice, followed by IVIG. If you're dealing with dysphagia, calcinosis, infection, malignancy, pregnancy, then I think we'll go for IVIG directly. And what has happened in last 5 to 10 years is our understanding about myositis pathogenesis has increased significantly, and also the drug repertoire of rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis has increased significantly. So what we are now able to do is borrow those drugs and look at our pathogenic pathways and see where best we can block the pathway using the drugs. And that has led to an explosion in myositis pipeline where various drugs are being looked into myositis. And this is just a slide of myositis pipeline, and you can see various drugs are in phase two stage of treating myositis. So the various phase two trials are going on, but there are few phase three trials which holds most promise, at least for this year. The results should be out for IVIG by end of this year. Also, there's a Baracept trial going on, which probably would be done this year, but results will be out next year. And lenabosum and sub-Q IG trial just got started recently. With that, I would like to summarize. Obviously, we do fair amount of clinical trials, and I often think about if my patient has failed first, second line treatment, then they could be a candidate for clinical trials and experimental drug. But last but not the least, in fact, maybe the most important point that I would like to make of this lecture is do not forget exercise. Because various studies have shown that exercise is anti-inflammatory. Studies from Sweden by Ingrid Lundberg have clearly proven that early exercise is better than late exercise. More exercise is better than less exercise. Obviously, you have to make sure your patient tolerates the exercise, but exercise has anti-inflammatory properties, at least to the muscle, and should be started as early as possible, maybe initially with physical therapy. Subsequently, a patient could do that themselves at home. With that, I would like to close this lecture and thank you very much for listening. And I welcome any feedback or questions at this point. Thank you.